but I would just request the first speaker, Dr. Sayan Basu, who is a clinical scientist from L.V. Prasad Eye Institute, doesn't need any introduction. He would be talking to us on overview of dry eye.
All right.
Over to you, Dr. Sayan.
Thank you so much, Horace. Good afternoon, everyone. So, I'm already a little bit delayed, so I'll be brief, crisp, and hopefully we can have a little bit of interaction during this session, a little bit of Q&A. Okay? So, I'll present very quickly on what I think about dry eyes and how I think that we can approach it in a way that we can give the best outcomes to our patients. All right, so a lot of the work that we're presenting is not just my own work. You know, we have a very large team that works together dealing with these very difficult patients. Most of them have chronic illness and they've been suffering for a long time and they have other complex issues. So it's not possible to present this without acknowledging their support. We are also very fortunate that we have a very successful and productive collaboration with the Narayan Netralaya group in our dry eye efforts, and we try to work together. One of the examples of this collaboration was the dry eye special issue which came out in the Indian Journal of Ophthalmology last year in April. For those of you who haven't had the chance to look at this, please take a look at this wonderful collection of over 60 articles which really addresses dry eye disease from A to Z, and you will find that you'll find those articles very helpful, particularly the review articles and the consensus papers. So I'll just highlight a few of them. The first one is on aqueous deficient dry eye disease. These are preferred practice pattern guidelines on clinical approach, diagnosis and management. Again, all of these IGO articles, as you know, are free to download. They are open access. You can also scan the QR code on the screen and get to the article directly. There's also another one on evaporative dry eye disease. This is particularly very useful because it gives a very, very lucid and practical approach to managing evaporative dry eye, which is the most common form of dry eye that we see in the clinic, and often is very challenging because we are not able to make sense of what to do. But you'll find there's a section in this article also on patient counseling, which you'll find very useful. And then this paper on topical and systemic immunosuppression in aqueous deficient dry eye disease. I think we'll talk about this during this session as well, where you will realize how how to basically optimize immunosuppression therapy and not to use it as blanket therapy everywhere, and how that can give you good outcomes. But this gives you a very good overview. So please take a look at these articles as well. I'll start with a few clinical cases. The first one, this patient is a 35-year-old teacher who complains of foreign body sensation, grittiness, dry eye symptoms, has about 6 to 8 hours of screen time, complains of burning sensation in both eyes. Patient is male, good vision, there's just a tiny bit of corneal staining, a few spots, normal TI meniscus height, normal Schirmer's, and a little bit of a less nid bud. So this is the meibography image. You can see the meibomian glands are a little bit distorted over here, curled, and you can look at the morphology and see that this is not normal. And there are some areas of dropout as well. You can see that in parts of the eyelids, the glands are shortened. So this is a very easy diagnosis. What is this a case of? This is a case of evaporative dry eye, meibomian gland dysfunction. So you will treat the patient along those lines, okay? But you can also have sometimes, and this is why I think meibography is useful, you don't necessarily need a high-end equipment, but if you have any infrared camera, you can image these glands. Sometimes you have cases with a more severe presentation. This is a 29-year-old female, exactly same symptoms and presentation in terms of the clinical signs, but you can see on meibography that the glands are completely atrophic. Now these are two ends of the spectrum of the disease, but it's important to recognize that meibomian gland dysfunction can also vary in terms of severity. Because in this patient, if there are no meibomian glands, then you cannot get them to function again by your targeted therapy at the meibomian gland. And there are very good ways of doing it, but it just won't work in these patients. So it's important to distinguish how you can personalize your treatment based on what severity and kind of pathology the patient has. Why do you think this patient has dropout? She's only 29 years old, very young female, healthy otherwise, but no meibomian glands. Any guesses? What kind of drug? So you're very close. This is basically because of the fact that the patient is on treatment for acne. So retinoids which are given for acne, you know how they work. They basically work by acting on the sebaceous glands and causing sebaceous gland atrophy, because acne basically is sebaceous gland hypertrophy. And the meibomian glands are nothing but modified sebaceous glands. So patients who are being treated for acne, patients who are being treated for PCOD, who are on hormone replacement therapy, can develop meibomian gland atrophy. So it's important to recognize. So if you see a female patient, young or middle-aged, who has severe meibomian gland dysfunction, evaporative dry eye, don't forget to do a meibography and look for atrophy of meibomian glands. So otherwise, the treatment is very straightforward. You give lubrication for symptomatic relief. Blinking is very important in addition to warm compresses. LipiFlow, IPL, Thermoflow, all of these things work, but it's important to understand, and we highlighted this in the review article as well, that many of these treatments need to be repeated. So you have to understand that it's not like cross-linking or not like LASIK. This is how sometimes it is marketed as. It's a one-time treatment. It's not. You can do it, it will benefit, but for a short period of time you will have to repeat it. And please, in these patients who have severe disease, keep it in your mind that this could be a reaction to hormone replacement therapy or to PCOD or acne treatment, and take that history. The other gland that we often don't talk about in dry eye disease is the lacrimal gland. This is a very easy test that I would recommend that all of you learn and use in your clinic. We call this the direct assessment of tear function, or DATS. You just take a fluorescent strip, dry strip, just like you do a Seidel's test, and you touch the lacrimal gland with it. You can expose the palpebral lobe of the lacrimal gland by just pulling on the outer canthus and asking the patient to look down and out, and the palpebral lobe will prolapse just like you see in this photograph, and you usually see this nice lobulated structure. And when you touch the gland with the strip, you will see the aqueous drain out, the aqueous part of the tear film drain out of the glands. Remember, the only caveat here is don't use topical anesthesia. Don't use topical anesthesia in general while evaluating your dry eye patients, because there is a reduction in the reflex arc and the patients will show symptoms or signs of dry eye because of the anesthesia itself. So that is one important caveat. So this is a very easy test, just putting the strip on the lacrimal gland and looking for effusion of fluid. And if you see 3 to 5 spots through which fluid is briskly flowing out, it means that the patient does not have aqueous deficiency. And then you look at other causes. If you find that the number of openings are less, 1 or 2, and the fluid is not coming out immediately, that means that there could be aqueous deficiency. It's a much direct and better assessment of the lacrimal gland function than Schirmer's, which is a surrogate measure, because you're looking at how much fluid is there in the cul-de-sac, and that fluid may not necessarily be from the lacrimal gland. It could have been just drops that the patient has put before entering your clinic room, or it could just be the topical anesthesia that you're using. So in lacrimal gland dysfunction, the most common cause is Sjogren's syndrome, which is autoimmune. Therefore, you must, if you're managing these patients, collaborate with a rheumatologist, and anti-inflammatory therapy, both systemically and topically, is very important in the management of aqueous deficient dry eye, and consultation with a rheumatologist is important. Also, do keep in mind that patients who are on neurological medications, particularly antidepressants and sleeping pills, can also manifest this pseudo aqueous deficiency where the lacrimal gland is just slow to function. So do take a history if they are on those kind of neurological medications, and sometimes reducing the dose or stopping the medications themselves can relieve the patient of the symptoms. In general, we look at all of this. Typically in aqueous deficiency, you have this intrapalpebral SPKs or staining. Patients have history of, if they have history of dry mouth or joint pains, then it's probably Sjogren's. They can have a history of bone marrow transplantation or hematopoietic stem cell transplantation, where the cause is GVHD, and they can also have skin or mucous membrane involvement and conjunctival cicatrization. This is something that we often miss in patients with aqueous deficiency, and you should look for other signs of conjunctival damage in these patients. And typically they will have low Schirmer's, low DATS, and low TMH and NIDBUD. So this is typically what a patient of Sjogren's looks like: interpalpebral staining, low Schirmer's, low DATS. And if you investigate, send the patient to a rheumatologist, investigate, then you will find that they are serologically positive for something. In this specific case, the patient who had rheumatoid arthritis, anti-CCP was positive, rheumatoid factor was elevated, ANA was positive, and the patient was put on systemic medication for the same. This also shows staining. This is also aqueous deficient dry eye, but this is not because of Sjogren's syndrome. You can see here the staining is very different. It's localized in the right eye to the nasal half and in the left eye only towards the superior and inferior cornea. So it's very easy to, this is obviously aqueous deficiency, but it's easy to confuse this with Sjogren's syndrome, and you can start the patient on anti-inflammatory, etc. It will not get better because the pathology is somewhere else. So here the reason is lid margin keratinization because of Stevens-Johnson syndrome. So if you have a patient of aqueous deficiency, please look at the conjunctiva for signs of cicatrization, because then otherwise you might miss the cicatrizing causes, which are rare but more difficult to treat, like SJS in this case. And there are various causes of cicatrizing conjunctivitis, and you can go through this review article as well, and you can again scan the QR code if you want for download the article for free, where the very nice algorithmic approach is described. But in general, it's basically because of 4 diseases in our population. The most common is Stevens-Johnson syndrome. They have a history of a dermal disease where there's shedding of the skin, etc. It can also be because of mucosplenic pemphigoid, where you need to refer the patient to a cornea specialist and ocular surface specialist, where this requires a very specialized therapy. Dr. Sangwan will talk about it. And it would also be drug induced. This is very common, and often we miss out on this. Again, another very nice review article on this topic. Most commonly due to topical anti-glaucoma medications, but it can also be because of systemic medications. Nowadays, the commonest form that we see is because of anti-diabetic medications like gliptins. So gliptins can cause a disease which is called gliptin-induced bullous pemphigoid, which causes conjunctival cicatrization and dry eye. So in these patients who you're suspecting with pemphigoid or cicatrizing conjunctivitis, please take a history of use of oral gliptins. Okay? So this is very common now with the use of preserved glaucoma medication and the very, very rampant use of gliptins for the management of diabetes. They're very good drugs. They don't cause hypoglycemia, but they cause ocular surface disease. Just last 30 seconds on the treatment. We know we have so many options, and I like to divide it kind of into these 2 groups of lubricants and anti-inflammatory therapy. In lubricants, you have these choices. On the anti-inflammatory side, you have the other choices. Remember to use topical steroids very sparingly, only when there is acute exacerbation of symptoms and flare-ups. And typically in aqueous deficiency, I will use a CMC 0.5% as my base drug. 2 reasons. One, frequent application, and therefore you have to understand that there is a financial element to this dimension to this equation, and CMC 0.5% is price regulated, so it's easy for patients to use this as a sustainable therapy. Topical cyclosporine is very, very important in the management of aqueous tear deficiency. It's very good now that we have so many alternatives, options in terms of topical cyclosporine. In evaporative, you would use one of the more viscous tear substitutes, and there the role of anti-inflammatory medication is not so much. This is what I will leave you with, the final algorithm. So consider dry eye disease in patients who complain of it, and confirm you don't need too much fancy equipment to diagnose dry eye disease. You just need a fluorescent strip. So with the fluorescent strip, look at staining. If there's staining on the cornea, if the breakup time is low, then the patient has dry eye disease. So symptoms plus staining plus low breakup time is that. And then you can also use the Schirmer strip to do a direct assessment of tear function or lacrimal gland and differentiate whether the patient has meibomian gland dysfunction or lacrimal gland dysfunction. Then you categorize. I think it's very important to separate these 2, where the lacrimal gland is involved and where the meibomian gland is involved, and treat them as such. And in evaporative, you also need to, in some cases, I showed you meibomian gland dysfunction, but you can also have evaporative dry eye because of exposure. And so nocturnal lag of ophthalmos is something that you need to rule out in some of these patients. And then finally, in aqueous deficiency, like I said, differentiate Sjogren's from cicatrizing and treat based on the cause, and the other speakers will allude to this in the end. So in the end, dry eye disease is a huge spectrum, and you must narrow down the cause. Treat the cause first and then treat the symptoms. Right now, I think the mistake that most of us do is that we only give palliative or symptomatic treatment to dry eye disease. It's a little bit deeper than that. So it's important to make these distinctions and then treat the patient based on what they actually have or what is causing the dry eye. Thank you so much.